Good afternoon, everyone. We are just starting our webinar on tobacco treatment delivery in cancer patients in Europe. So before introducing quickly the participants, the speakers, I would like to provide you with some housekeeping information. So it is important that you are all muted while the speakers speak. If you have any questions, please put your questions into the chat box so that we can gather them and then use them for the Q&A session. So now I briefly go around all the speakers without introducing them in detail, and then we will move from there. So we have at this roundtable discussion Oksana Domenti, who is WHO from the WHO representation to the European Union.
Good afternoon, everyone.
Then we have Giuseppe Gorini from ISPRO, Italy.
Good afternoon to all.
Then we have Haris Girvalaki from ECPC, the European Cancer Patient Coalition.
Good afternoon.
We have Krzysztof Prewozniak from the Marie Curie National Research Institute of Oncology in Poland. Okay, and then we have Krzysztof, you're on mute. Sorry. Krzysztof? Okay.
Good morning, everyone.
Okay, thank you, Krzysztof. And we have Jacqueline Daly, Secretary and Board Member at ECPC, the European Cancer Patient Coalition.
Good afternoon, everybody.
Thank you all. So just a quick introduction because we do have a very packed agenda. This event has also been endorsed by the Parliamentary Intergroup on Cancer, so by Challenge Cancer, and we also received a video message from MEP Bushoi, who will be featured later on. In Europe, although it is well established by now that approximately 30% of cancer deaths are directly caused by smoking, and there are evidence-based interventions, including behavioral therapy available, which can double or triple the rates of successful quitting, they are often neglected and they are not incorporated in cancer treatment and recovery. So continued smoking after diagnosis affects the treatment outcomes, increases the mortality rates after treatment and the recurrence of cancer, while increases the risk of new cancer. On the other hand, quitting smoking after the cancer diagnosis can improve the treatment outcomes, prolong survival, and reduce the risk of new cancers. So with this webinar today, we want to address the importance of smoking cessation during or after cancer treatment. And we want to highlight the feasibility, availability, and the cost effectiveness and efficacy in cancer treatment success and cancer recovery. So those are the main topics that we will touch upon today. Now I give the floor to Cornel for a quick welcoming.
Thank you very much, Antonella, for this, let's say, comprehensive introduction. And for us, for ENSP, it's a very important webinar event. Unfortunately, we planned this event as a face-to-face event during our annual conference, European Conference on Tobacco Control, but unfortunately it was not possible. So it's good that we found a way to work together also on the virtual, let's say, reality. And I welcome all of you, all panelists, all the participants. And for me, it's a pleasure at the beginning to introduce Dr. Oksana Domenti. She is the WHO representative here in Brussels at the European Union. Before, she was an advisor to the regional director of WHO Europe and also a member of the Parliament of Moldova and an advisor of the President of Moldova. So please, Oksana, the floor is yours, please.
I'm sorry. Dear colleagues, dear friends, can you hear me now? Cornel? Yeah, okay. It's a great pleasure for me to open this important event on tobacco cessation in cancer patients and speak today on behalf of the WHO. And let me start by expressing gratitude to both organizers of today's webinar, the European Network for Smoking and Tobacco Prevention, and the European Cancer Patient Coalition for this amazing initiative to join forces together in the fight against cancer, but also for their long-standing efforts and contributions for better health in Europe over the years. More than 18 million people were diagnosed with cancer around the world in 2018, and cancer is the second leading cause of death globally, with an estimated 9.6 million deaths worldwide attributable to all types of cancer in 2018. We all know that cancer represents an enormous physical, emotional, and financial burden on individuals, families, communities, and health system. A burden that continues to grow in all groups of countries, with the greatest increase in low and middle income countries. According to the latest data available, total annual economic cost of cancer is estimated at approximately $1.2 trillion US. With less than 10% of the world's population, Europe accounts for a quarter of all cancer cases, estimated to have risen to 2.7 million new cases in the first half of 2020, with 1.3 million deaths. Despite continuous improvement in survival rate, probability of survival, as you know very well, varies across Europe with significant inequities in prevention, timely diagnosis, treatment, and care. Increasing survival means that more people are living with and after cancer. WHO, through its global 13th General Program of Work, but also through recently approved the European Program of Work, United for Better Health in Europe, is determined to support member states in improving equitable access to prevention, diagnosis, and treatment of cancer patients, that reducing inequalities and moving toward universal health coverage while promoting health and well-being, improving quality of life of survivors and their families. All these services have in different degree been negatively affected by the COVID-19 pandemic and requiring bigger effort from all of us. As over the world, the cancer survival rate improves and lifespan increases, it is important to improve the cancer treatment outcomes and quality of life of these patients. And one way is clearly through addressing tobacco use in patients diagnosed with cancer. Tobacco use, the most important factor for cancer, is well documented. In fact, an estimated 22% of cancer deaths are attributable to tobacco use, but less is said on the effect of tobacco on the patients already with cancer. However, existing data suggest that tobacco use by cancer patients is linked to increased risk of adverse cancer treatment outcomes, including overall mortality, cancer-specific mortality, and second primary cancers, increasing treatment-related complications and tobacco-related comorbidities, such as cardiovascular and respiratory diseases. That tobacco cessation should be an integral part of cancer care in order to maximize the benefits of patients' cancer treatment. All these patients who use tobacco have to be identified and offered smoking cessation support. Brief tobacco interventions must be incorporated into all healthcare systems, including oncology clinics. Reducing tobacco use prevalence among cancer patients with reduced and avoidable burden of morbidity and premature mortality in patients with cancer. Sustainable funding should be identified and allocated to dedicated tobacco cessation services, to tobacco treatment training programs for healthcare providers, and for research in this area. Along with this, the evidence-based tobacco control measures envisaged in WHO FCTC have to be implemented in all countries. This includes smoke-free legislation, mass media anti-tobacco campaigns, labeling of tobacco products, and increase in taxes of these products. Tobacco control is about saving lives, about preventing disease, and about discouraging an addiction. And support to tobacco cessation of cancer patients is about improving treatment outcomes and quality of life of cancer survivors. I wish you every success with this symposium, and I very much hope we will continue our cooperation in this important area. Thank you very much. Over to you, Cornel.
Thank you,
Antonio.
Yeah, thank you, Oksana. We do appreciate your welcoming, and we do appreciate the constant support that we have received from WHO, of course, on this topic. Now we have a video message from MEP Christian Bouchoy. He's currently the chair of the newly established parliamentary intergroup on cancer called the Challenge Cancer, and is also chair of the European Parliament Committee on Industry, Research and Energy, the ITRE committee. Mr. Bouchoy has always been very close to ENSP and to ECPC on tobacco control issues and on cancer issues. In fact, he's chairing, and he was the promoter of the parliamentary intergroup. So unfortunately, as he's extremely busy, he could not be with us today, but we do welcome this video message that he sent us. I think we have some problems because I cannot hear you. I cannot hear him. I don't know if it's only my problem.
We'll fix in 1 second, please.
Yes, okay, no problem.
To you today. I would also like to thank all those present for their active participation and for their involvement in such an important topic as tobacco control and impact of tobacco on cancer patients. During my time as a politician working in European Parliament, I have witnessed the preparatory work for the adoption of the so-called Tobacco Products Directive, the implementation of its provisions, seminar discussions with various associations on the link between tobacco and various diseases, on the need to further address the health risk factor. In Europe, every year, the fight against tobacco use involves hundreds of associations, thousands of volunteers, and many MEPs and members of national parliaments in all around Europe. Indeed, the use of tobacco diminished, but there are still concerns. Tobacco control has made progress. The legislative mechanism and tax measures resulting from World Health Organization recommendations are beginning to be implemented, but still we need to further improve the implementation of the FCTC. Today we have 3 billion smokers worldwide. 8 million die every year, including 1 million non-smokers, according to World Health Organization figures. In Europe, 700,000 people die prematurely every year. Women lung cancer rates are exploding. The social cost of tobacco, premature death, medical expenses, sick leave represents several hundred billion euros per year for EU member states and remains on the rise, while tax revenues from tobacco sales are 6 to 8 times lower and continue to decline. The aim of our meeting today will be to address the importance of smoking cessation during and after cancer treatment. Smoking is #1 preventable risk factor for many diseases, including cancer. Tobacco smoking is known to be the main cause of several cancer types, and continuing to smoke after cancer diagnosis is associated with decreased overall and cancer-specific survival and increased risk of cancer recurrence, treatment toxicity, secondary malignancy, depression, stress, and reducing quality of life. Despite this, up to 50% of patients who are smokers before a cancer diagnosis continue to smoke during treatment. For those reasons, smoking cessation interventions should be a part of standard oncologic treatment and also from the promotion programs and early screening strategies in the field of cancer. Thank you, and looking forward to the meeting conclusions.
Yes, indeed, we always had full support from Mr. Bouchoy and also from, let's say, other members of the European Parliament, especially the ones involved in the cancer groups and in the ENVI committee. Now I have the pleasure to invite Giuseppe Gorini from ISPRO Institute in Italy, and his presentation today will be about the efficacy of smoking cessation after cancer diagnosis. And he will present some data from Europe and some good practices. So please, Giuseppe.
Thank you very much for inviting me to this interesting session. I am showing my presentation. Do you see it? Can you see it? Okay.
Yes. Sir.
So I'll speak about the efficacy of smoking cessation after cancer diagnosis in Europe, but not only in Europe, also in Northern America. We know that smoking cessation intervention in cancer centers are rarely recommended because it's likely that the health professional perceive smoking cessation to be too late and patients not receptive. This is very common, at least in Italy and I think in other European countries. But we know from literature, above all from, for instance, this systematic review from the US Surgeon General's report published in 2014, that there are substantial health benefits after smoking cessation that are improvement in general health, improvement of all cause and cancer-specific mortality, and moreover, very important, reduced toxicity of treatment and greater response to treatment, and also decreased risk of disease recurrence and second primaries, as Oksana already said about it. But anyway, even for instance, early stage of lung cancer improves prognostic outcomes with smoking cessation. When I speak about early stage of lung cancer, I mean stage from 1 to 3A of non-small cell lung cancer and stage 1 and 2 of small cell lung cancer. And even, for instance, this is a very famous review published in BMJ 2010, so 10 years ago, and you already knew that also even in early stages of lung cancer, smoking cessation is very important, is very effective in order to improve quality of life and also treatments and prognostic outcomes in general for these patients. But I'd like to show you a practical example that is from the Ontario Cancer Care. That is, Ontario is a state in Canada, and they already deal with this issue. So to deal with a brief intervention for smoking cessation in cancer care, not in, for instance, not only in general practitioners, clinics, or for instance in other settings. Here is the Cancer Care Ontario, and this is a poster they put in all outpatient clinics in order to remember to the health professionals, but also to patients, to speak about smoking. And there are the 3 A's, that is a short form of the 5 A's of the very famous brief advice for smoking cessation. Ask, and this is the script of the question that the health professionals should deliver to patients. Advice, for instance, quitting is one of the best things you can do to help your cancer treatment work better and reduce side effects. Being smoke-free will also reduce the chance of your cancer coming back or getting another kind of cancer. And the most important sentence is this one: it's never too late to quit. And the last part, the last A is act, and is the referral system. So I understand that quitting or reducing or staying quit can be hard, but it's easier if you have help. I'm going to refer you to, in another slide, all the tools we can provide to patients, to offer to patients in order to stop smoking. But for instance, this is the script for health professionals. The questions, this is in their duties, but they have to document the patient's response on the ask, on the point of ask regarding do you smoke cigarettes? They have to document whether the advice was given from the patients. And also they have to document the type of referral selected by the patients, or if the referral was refused. So they not only they deliver this type of intervention, but they also monitor what they are doing in order to be responsive of what are doing regarding smoking cessation. But also they also developed a website and videos for training health professionals. This is an example of their website. There is a videos explaining how to deal with the problem of smoking cessation in a cancer patient, with a cancer patient. Another script I'd like to show you that is very simple and very useful to deliver to patients in order to stop smoking, to cancer patients, is this one. This is also a poster they put in the outpatient clinics. For instance, for there are treatment-specific advices. For instance, for surgery, if you quit smoking, you are less likely to have infections or complications. Quitting smoking makes surgery safer and helps you recover faster. This is the same sentence we saw before. It's never too late to quit. Moreover, radiation therapy works better when the amount of oxygen in your body is normal. When you smoke, your oxygen level drops. Quitting smoking helps the radiation therapy work better and may reduce side effects. And finally, chemotherapy. Cigarette smoke has chemicals that can lower the amount of some chemical therapy drugs in your blood, making them less effective. Quitting smoking helps chemotherapy drug work better in your body. These are very simple questions, simple sentences, but very simple, but also full of reasons in order to let the patients stop smoking or thinking about stop smoking. Going ahead, I'd like to say that the vision for cancer care Ontario smoking cessation interventions was to ensure that cancer patients in Ontario achieve the best possible health benefits from their cancer patients. It's important, the vision, because the focus is on the health benefits, the quality of treatment that they are delivered to patients. Because stopping smoking treatments are more effective. And so it is framed, smoking cessation, in this vision that I think it's very important also for us in Europe. And now I want to speak a little bit about the referral systems, and to begin with, to speak about Europe. Because when the patient, the third A, do you remember the act? The health professionals have to refer cancer patient to some tools or services in order to that help a smoker to quit. This is, for instance, in Europe, this is the first problem, because in Europe we are not it's difficult that all these tools, and I show you briefly, are developed or well developed. For instance, smoking cessation centers where to refer the cancer patients in the hospitals or in the area of residence of cancer patients. For instance, in Italy, we have a lot of smoking cessation centers, but they are embedded in other departments, for instance, drug addicted departments or pneumologist departments, and few hours are dedicated to smoking cessation in these departments. I think that in some European countries, not all European countries, smoking cessation services are well developed. For instance, quit lines is another tools, if available. For instance, in Italy, we have a national quit line, but it offered to patients or cancer patients only one call, not the 3-4 calls that are provided by the WHO guidelines on quit line. So the quit line has to follow the patients during its quit attempt, his or her quit attempt. But for instance, in Italy, it's not possible to follow all the patients because the quit lines is not well developed. I think that this is a problem also of many European countries. And the last point, and I think the most worrying, is regarding digital media interventions. That I mean, for instance, web-based interventions, such as the ex-smokers are unstoppable, that was developed by the European Commission, but unfortunately was over because there were no more fundings for this campaign that was very useful because it was a campaign with also a eye coach, a sort of one of the first generation text messaging based interventions. Or for instance, the so-called Stop October campaign developed in UK, but also the Moi Sans Tabac in France, or the same Stop October in the Netherlands. There are campaigns in order to improve, to promote smoking cessation among patients, among people, and also among cancer patients. But in Europe, I think that these digital media interventions, for instance, also applications for mobile, are not well developed, and above all, are not developed by national health systems or the Ministry of Health of some European countries, and there are only some tools, some devices that are produced by companies that, and I think that this area should be developed very well. Going ahead in Europe, what is the main problem? Is that ascertainment and treatment of smokers use an opt-in design and is not well embedded in patient pathways. What does I mean? Opt-in design means that if the smokers ask for help, they are addressed to some services or tools or devices and so on. Instead, the opt-out design approach is that where all smokers that are, for instance, hospitalized for a cancer or other diagnosis, all these smokers are offered smoking cessation interventions. But they are free not to accept or to accept. Moreover, training in smoking cessation interventions for healthcare professionals is inadequate. And the smoking cessation or the issue of smoking is most commonly taught as part of a more general topic such as health promotion. So some solution could be that European countries should adopt an opt-out strategy for smoking cessation in order to ensure to all smokers that are, for instance, hospitalized for a diagnosis of cancer, are addressed on the problem of smoking. And so the ascertainment and treatment of smokers become a core of the activity of the national system. Moreover, the training in smoking cessation should become available into all undergraduate and postgraduate healthcare professionals curricula, not only physicians, not only drug addicted therapists or psychologists, but above all nurses, midwives, and all the health professionals that have to meet cancer patients. For instance, in the US, US hospital has to offer tobacco cessation counseling and pharmacotherapy to all hospitalized smokers. They have to follow up smokers within 1 month after hospital discharge and to provide or refer smokers treatment resources after discharge. These three objectives are linked to key performance indicators of the performance indicators of the hospital. So here, dealing with smoking cessation is not something that is left to the single health professionals. They have to do because the performance indicators of the hospital are linked to smoking cessation. They have to show that they are dealing with smoking cessation. Similar approach was developed in Canada with the Ottawa model for smoking cessation. So my suggestion is to begin to think about a new approach on dealing with smoking cessation among, above all, cancer patients, but not only cancer patients, to all the patients that entered into contact with the hospitals or other health services in Europe. Thank you very much.
Thank you, Giuseppe, for this comprehensive presentation on why cancer patients should quit smoking, as the tobacco smoke has a huge impact on their treatment, and what is available for them in order to be helped to quit smoking, and actually how countries are not always aligned on supporting cancer patients to quit. So quite interesting, and I also enjoyed your recommendations to support cancer patients to quit from a policy level up to an implementation level, including education for healthcare providers. So that was very interesting. Now I give the floor to Haris Hirvalaki, who's EU Affairs Manager at the European Cancer Patient Coalition. And she will speak about tobacco treatment delivery for cancer patients and behavioral therapy and pharmacotherapy. So Haris, the floor is yours, and please stick with the time because we have 2 more presentations plus the Q&A session. So thank you, Haris.
Thank you very much, Antonella, and thank you everyone for joining this webinar today. So what I'll be speaking is that on tobacco treatment delivery for cancer patients, and specifically on behavioral therapy and pharmacotherapy, but I don't know why it does not change. Okay, I guess that here. Okay, sorry. But before this, I would like to mention a few things about the real problem. So it is well documented that tobacco smoking is strongly associated with a number of malignancies. But unfortunately, there is a historical disconnect. And it is that we stop working on this after cancer diagnosis. But in reality, as you can also see on the slide, we have biological, clinical, and value-based outcomes that are very real and important when we try to manage cancer. So when we break this barrier, we can look at how smoking cessation can affect these outcomes. One of the biggest areas of support for this was the 2014 Surgeon General report, which was the first study that looked at what are the effects of smoking on cancer treatment outcomes. I will not repeat as the previous speakers have mentioned. This is also another study which investigated the attributable failures due to smoking. And you can see here that failure rates of first-line cancer treatment in smoking cancer patients increased due to smoking, and also that smoking is associated with substantial increases in the cost of subsequent treatment after failure of the first-line cancer treatment. This in US specifically resulted in $3.4 billion annually spent on cancer drugs for treatment failures due to smoking. So you may probably wonder if there is anything that we can do about it. And this is where smoking cessation right now is the best opportunity that we have if we want to try to improve these outcomes. In 2020, recently, Surgeon General went back and took a look at what are the effects of quitting after cancer diagnosis. And as you can see, unfortunately, there were not so many studies, up to 10, to evaluate this, but the conclusion was associated with improved all-cause mortality in cancer patients. So practically, when it comes to smoking cessation interventions, there are several forms, such as behavioral interventions and smoking cessation pharmacotherapy, as well as the combination of those two. In this table, you can also see smoking cessation interventions can raise up to 6 times the chance for a successful quitting when it comes to the combination of behavioral counseling and pharmacotherapy. These results, of course, are for healthy populations, but even with not the same intensity, we can say that it is also applicable for cancer patients. One of the most famous models, the recommendation for brief tobacco treatment in clinical settings, is the 5A's model, which consists of ask, advise, assess, assist, and arrange. And a very recent European study from 16 countries interviewed oncologists from clinical settings and palliative settings, and the findings showed that 92% of the oncologists asked their patients, 88% of them advised them to quit, but then when it comes to the assistance, we can see that these numbers dramatically drop to 18% for assistance and 24% for discussing medication. When it comes to the palliative settings, these percentages are even lower, while the most important barriers as identified by the oncologist are the lack of time, the lack of training, patients' resistance, and lack of resources. Here you can also see some very well-known behavioral counseling interventions for the healthy population, but when it comes to cancer patients, even though studies are limited, individual counseling and group counseling are among the most effective. While a broadly used tool is the motivational interview, which aims to work with patients' ambivalence, and a recent systematic review on cancer patients and survivors showed that motivational interviewing is a promising tool for promoting health change across a variety of cancer types and treatment stages. When it comes now to first-line smoking cessation pharmacotherapy, with proven effectiveness on healthy populations, there are several forms available, and with regards to the limited studies that we have for cancer patients, we can say that nicotine replacement therapy, along with behavioral and other pharmacological treatment, is proven to be effective in head and neck cancers, as it is in general population. Varenicline is very well tolerated by cancer patients, while bupropion has been administered to cancer patients during treatment, and it was found to improve their mood and facilitate smoking cessation. We must note here about bupropion that due to its a side effect to cause seizures, even if in a very small percentage, and also to be known that it reduces weight gain, this must be taken into account from oncologists when they are advising their patients on smoking cessation therapy. And some take-home messages from my presentation is that quitting smoking at diagnosis can actually improve patient treatment effectiveness, overall outcomes and quality of life, while cancer diagnosis may be a useful and teachable moment for quitting smoking, but this chance is frequently undervalued by the healthcare systems in Europe. For that reason, we strongly believe that smoking cessation should be included to standard care for cancer patients, of course, with the provision of behavioral and pharmacological support for cancer patients. And another issue that I would like to address is that there is a necessity for EU legislative measures to reinforce smoking cessation, and specifically WHO Article 14, so that synergically with other tobacco control policies in Europe, they can reduce the burden of cancer in Europe. And also another important and last step is that we support smoking cessation treatment research for oncology patients. Thank you very much.
Thank you, Haris, very much. So indeed, a very interesting presentation. And as far as I see, we have a lot of participants working in this field, and I think this is very useful for them. But also, I would like to mention the fact that ENSP is involved from, let's say, many, many years in this field, and we published a lot of tobacco dependence guidelines. We have an e-learning platform to help the health professional to gain more knowledge in this field, and I kindly recommend to all interested people to access the guidelines, to check the e-learning platform. And now I am moving to the next speaker, and Krzysztof Przewoźniak from Poland, from the National Research Institute of Oncology. He's also an ENSP board member, and he will speak today about something very, let's say, actual, something that is around us, and is the link between tobacco use, smoking cessation, and this new epidemic related to the COVID-19. So please, Krzysztof.
Good afternoon, everyone, once again. Hello?
Yeah, we can hear you very well.
Yes, I hope in a second you should see my presentation. Something happened.
You have the PowerPoint on the bar down, so you can just open
it. Do that once again. Okay. Do you see the screen?
Yes, it's okay. It's okay, please.
Okay. So my task today is to say briefly about tobacco use and smoking cessation during the COVID-19 epidemic, and first of all focus on recommendation for smokers and cancer patients. I've been not talking about potential problems in smoking cessation that we have in cancer hospitals and in cancer smoking cessation clinics. I'll be almost exclusively focusing on the new health challenge that we have since March this year. The objective of the paper is to evaluate changes in trends and patterns of tobacco use during the COVID-19 epidemic and recommend on health behaviors for tobacco and e-cigarette users, with special focus on cancer patients and patients with other severe health problems. What kind of material and methods I use for these presentations? I made a search for phrases tobacco use and COVID-19, smoking and COVID, vaping COVID, smoking cessation COVID on PubMed, Medline, Embase, Cochrane Library, Science Direct, and WHO Global Database. To your knowledge, only on PubMed, we have over 500 studies on smoking COVID-19, almost 150 studies on tobacco use and COVID-19, over 40 studies on vaping COVID-19 and 60 studies on smoking cessation COVID-19. The major study reviews and meta-analyses on smoking COVID-19 published this year include, first of all, WHO scientific brief and papers made by Emami et al., Farsalinos, Zhao, Guo, Zheng et al., Vardavas and Nikitara, Patanavic and Glantz and Grandier et al. I also use WHO country public health reports on COVID-19 restrictions, showing you how fastly smoke-free regulations are also enforced during the pandemic. Let me take first a brief look at relation between tobacco use and vaping and the COVID-19 risk on this basis. As tobacco smoking, I mean lung cancer, COPD, or emphysema, and vaping, I mean EVALI, contributes to damaging and respiratory system and to weakening of immune system, both smokers and vapers can be at higher risk of SARS-CoV-2 infections and have severe COVID-19 outcomes. Available scientific evidence suggests that both current and former smoking is associated with increased severity of disease and death in hospitalized COVID-19 patients. Some studies indicate that adult current smokers and former smokers appear to have higher odds self-reported COVID-19 compared with never smokers. There is also few studies that prove that or underline that smokers have increased airway expression of ACE2, which is the entry receptor for COVID-19 virus. Some population-based studies conducted both among adolescents and young adults prove that the use of e-cigarettes only and dual use with tobacco are at 5 to even 7 times increased risk of COVID-19 diagnosis when compared with non-users. However, there is no clear, at least by now, evidence in current peer-reviewed literature to quantify the risk to smokers of hospitalization with COVID-19 or of infection of SARS-CoV-2. So we need additional clinical and population-based studies to address questions about the risk of infection of SARS-CoV-2 and risk of hospitalization with COVID-19. What is the new phenomenon is that within the COVID-19 epidemic restrictions, we have around Europe, but also in other countries, new smoke-free regulation. This is, for instance, ban of outdoor smoking in some regions being at high risk of SARS-CoV-2 infections. The Canarian Islands are example of that. Ban of outdoor smoking in SARS-CoV-2 red alert areas, my country is example. Ban of indoor smoking in yellow alert area and indoor-outdoor smoking in red alert area in healthcare settings and hospitality public venues. There are many countries. As an example, US lawmakers sent a letter to the US FDA commissioner with request to withdraw even e-cigarettes from the market during the pandemic. Unfortunately, it didn't happen. And we have also potential reduction of exposure to tobacco smoking public places and work sites made by lockdown regulations. I mean about wearing of hygiene masks, limited access to tobacco shops, limitations in public places, and alcohol control regulation. What is the scale of such a new smoke-free regulation? I will give you a Polish example. You have on this map a red alert area for COVID. They contain over 70% of Polish population, 152 of 314 all countries, and 11 of 16 capitals of provinces, including Warsaw, the capital of Poland. So the scale of such a new smoke-free regulation is really big. Few words on tobacco use and smoking cessation during the COVID-19 epidemic. Observational studies say that smokers constitute from approximately 1 to 19% of hospitalized COVID-19 patients. A little smaller percent was found in meta-analysis. Most of population-based and clinical studies indicate on various behaviors on smokers during the pandemic. So in some countries and in some regions, some non-smokers start smoking, some ex-smokers get back to smoking, some smokers smoke more, and other smokers make attempt to quit smoking. Some studies conclude that boredom and epidemic restrictions might have stimulated smoking, while the threat of contracting COVID-19 and becoming severely ill might be rather have motivated others to improve their health by quitting smoking. UK ASH and UCL study underlines that COVID epidemic has contributed to a quite huge increase in quit rates in UK. This is estimated for over 1 million smokers who quit smoking during the pandemic. Vast majority of studies, and this is probably the most important conclusion, conclude that the COVID-19 epidemic creates an opportunity to stopping smoking. However, some studies recommend to use the proven evidence-based intervention and treatment methods. This is WHO report, while other reports also recommend smokers e-cigarettes as an option to add quitting. This is Public Health England reports. What are major recommendation for tobacco and e-cigarette users and cancer patients? And I'm also very open for any other recommendation that you have in your mind and send me after the webinar. The first is to reduce the SARS-CoV infection and severity COVID-19 outcomes. All tobacco smokers and e-cigarette users should utilize the COVID-19 restrictions and recommendation for making a serious quit attempt, or at least limiting the number of tobacco products or e-cigarette use. Second, for those smokers who are already infected by SARS-CoV-2, and especially those patients who are treated from severe and chronic diseases, including cancer, or have weakened the immune system, for example, by chemotherapy, stopping smoking is recommended as an essential condition of effective treatment. Third, all cancer patients, and of course other with severe and chronic diseases who smoke, should be informed about the increased risk of SARS-CoV-2 infection and severe outcomes of COVID-19 when smoking is continued. Fourth, which was, by the way, underlined also in previous presentations, the management of 5A smoking cessation intervention should be recommended for all patients who are infected by SARS-CoV-2, but especially those who are treated from severe and chronic diseases. All above groups of patients and additionally non-smokers should avoid SHS exposure and fully comply with all smoke-free restrictions, including those introduced with the COVID epidemic. All hospitals and other healthcare and social care settings where patients are treated on COVID-19 or are infected by SARS-CoV-2 should enforce indoor and outdoor smoke-free regulations. And last but not least, all tobacco and e-cigarette users should restrictively apply to all hygiene restrictions, including wearing of hygiene masks. Don't offer their own tobacco products or e-cigarettes to others. Protect others from touching their tobacco products. Sustainably remove cigarette butts. Wash and disinfect hands before and after using tobacco, e-cigarettes, and relevant devices. And if possible, don't touch face by contaminated fingers where hands are not washed or disinfected. And three major conclusions. The COVID-19 epidemic is a good opportunity to making serious quit attempts, smoking cessation, substantial reduction in tobacco or e-cigarette use, or limitation of SHS exposure to broader scale. Second, the epidemic is also a chance for strengthening smoke-free restrictions, especially at environment of high-risk groups and at those communities which are infected at high level, including red alert areas and social care settings. And last one, there is a need to continue studies on COVID-19 and smoking with special focus on the relation between the epidemic and smoking attributable mortality, including cancer, smoking prevalence and cessation rates, enforcement of new smoke-free intervention and regulation. These are the selected major references I use in my presentation. Thank you for your attention. Stay healthy and safe.
Thank you, Krzysztof. So now we needed to reassess a bit because we're running out of time. In principle, we have only 4 minutes for Jacqueline Daly to present her story. And then we needed to skip, unfortunately, the Q&A session. So for Jacqueline, Jacqueline Daly is ECPC board member, and she's also secretary at ECPC, and she's a cancer patient. So we will hear from her a patient testimony. So she will tell us about the emotional, psychological, and the social challenges that people are faced with when they make an attempt to quit smoking. So Jacqueline, the floor is yours.
Thank you, and hello everybody. I will make this as short as I can, so if there is time for somebody to ask questions, that will be great. As a cancer patient and a smoker, I knew everything that you've all said. I knew the risks that I was facing. I knew that my recovery time would be better if I didn't smoke. I knew that my risk of infection would be lower. I knew all of that, but that didn't stop me smoking. For me, I had tried 4 times to stop smoking. And then in 2006, I decided it was time that I tried again. The other thing that cannot be forgotten is that when you're told you have cancer, it is really poses an extra pressure on the person to try and give up cigarettes. So a support network is so, so important. In 2006, I spoke to my cousin and told him, you know, I feel I really want to stop smoking again. And he advised me to pick a date, to set up a network of people that I trusted to support me, and that to continuously work with them. And then he said something that totally shocked me. He said, you know, you have to realize that you're an addict. An addict? Me? No, I was a smoker. I wasn't an addict. But he was right. I was an addict. I was completely and utterly addicted to cigarettes. One of the things I soon realized that when I would light that cigarette and take that pull of the cigarette, my stress levels weren't being reduced. What was actually happening to my body was that calming feeling was coming from the relief of nicotine withdrawal. So my body was really glad to get that nicotine back in. When I realized that, it was so empowering, and it really enforced in my head that I was an addict. I think we need to really talk to smokers and let them know they are addicts. Addicts are not just alcoholics and people on drugs. One of the things I found really useful was I used acupuncture. And I really found that very, very successful. As I said, this was my 4th time to try. I'm now 14 years off cigarettes, but every day I get up, I know I am 1 cigarette away from being smoking again. So yes, the support needs to be there. I would love to see a network right across Europe where smokers can have a forum where they can actually support each other. Thanks to every one of you for today. And I said I will cut this short in case somebody else needs to say something. Thank you.
Thank you, Jacqueline. And I also needed to inform everyone that Oksana Domenti needs to leave us because of other commitments. So we thank her very much for making the effort to join us today and for contributing to the discussion. And of course, if there is any specific question, then we will bring it up to her later on. So now, for the Q&A session, I mean, we're supposed to close here now. We have received a couple of questions, and I'm not sure if we have time. Now I have to rely on Cornell. Maybe we
I think we can take one question, Antonella, please,
okay.
And then we have to close. Yeah.
Okay.
So, in any case, I saw that some questions are already answered online in writing. So.
Okay, so I don't, because I also don't see all the questions. Okay, so if yes, the questions are answered online, maybe there is this interesting question that was on heated tobacco and why couldn't we support heated tobacco as a harm reduction attempt to quit smoking. Maybe Giuseppe, you can answer this question verbally, even if it's already in the chat.
Yeah, I already answered, but anyway, I like to say that it's not necessary quit or die. This is a message that in a relationship with the patient, with the physician, is not useful to say or you quit or you die. As first line, of course, we have to recommend smoking cessation because it works better, because it's the best thing that the patient can do. But anyway, there are some addicted persons, some addictive smokers, as already said Jacqueline, and that it's difficult, for instance, at 50 years old to stop smoking because there is a cancer diagnosis. And the smoker is accustomed to use smoking in order to release stress. And so when you have a stressful information, such as having a cancer, it's difficult to cut this pathway to reduce stress using cigarettes. So as a second line, we could speak about electronic cigarettes. But anyway, in a sort of a relationship with the patient, I do not recommend as a recommendation at the population level. Only in outpatient clinics with your patient that has this problem, you can also suggest to use cigarettes. For HTPs, heated tobacco products, the problem is more complex because we know that some chemicals are reduced, but others are increased more than they are only in the HTPs, but they are not in traditional tobacco cigarettes. They are about 25 toxicants. So it's, to me, as a physician, it's difficult to say, use this one because some chemicals are reduced, but others are new. We don't know yet what exactly they are. So I think that to me, it's difficult to deliver this information for heated tobacco products. This suggestion to use heated tobacco products in order to stop smoking in a cancer settings. Okay.
Thank you, Giuseppe. So I think now we need to close because otherwise we run too much over time. I would like to thank all the panelists, but I would also like to thank particularly Jacqueline Daly to having joined us today, because on this kind of events we have always heard only one side of the story, and we really needed to involve more and more patients, or smokers in general, but cancer patients specifically now with ECPC. So Jacqueline, I'm sure that the ENSP will come back to you with more questions and trying to involve you more in all this kind of work.
Thank you.
Okay, so I thank you all. I thank again Oksana Domenti was to leave, MEP Bushoi. I thank Giuseppe Gorini, Haris, Krzysztof, and Jacqueline for being here today. And of course, my co-host, Cornel Radu in the ENSP. Okay, thank you everyone.
Thank you very much. Have a nice day.
Thank you to all. Bye-bye.
Thank you all. Stay healthy and safe.